Welcome to the deep dive. Today we are wading into some pretty complex territory clinical guidelines for liver conditions. Our mission, really, is to cut through that density and give you a clear, practical shortcut to understanding liver health. We want to pull out the key insights.
Absolutely. And we're covering a fair bit of ground. We'll be looking at the main viral types, hepatitis A, B, C, and E, but also, crucially, the non-viral issues like non-alcoholic fatty liver disease, NAFLD, and damage from drugs or alcohol, which are really increasingly significant.
Right. So the goal for you listening is this. Understand the risks, who gets these diseases, what are the signs, the markers doctors look for, and also why is the management, especially for the chronic forms, so centralized now? These conditions can be silent for a long time, until serious damage is done. Okay, let's start with the viruses. We can probably group hepatitis A and E together first, right? HAV and HEV.
Right.
These are generally the acute ones, the ones you get over, although they can certainly make you feel quite ill.
That's right. Hepatitis A, that's your classic fecal-oral route. Think contaminated food, water, poor sanitation. And it's worth noting, public health has actually made huge strides here. The general incidence of Hep A has really plummeted over the past couple of decades.
Yeah, I saw that. And the age thing is interesting, too. Kids under 5 might not even show symptoms, but older children and adults, over 75%, feel sick. Still, the good news is it almost always resolves completely on its own. No specific antivirals needed.
Hepatitis E is pretty similar in that it usually heals spontaneously, but its profile is changing a bit. We're actually seeing more cases reported lately, and it's not just linked to travel anymore, it's popping up domestically. There is one important caveat with HEV, though. While it's usually acute, it can become chronic, specifically in people who are significantly immunocompromised, like organ transplant recipients.
Okay, so A and E are mostly short-term issues, with that one exception for E. But then we get to hepatitis B and C, HBV, and HCV. And this is where the conversation shifts to long-term chronic threats, doesn't it?
Exactly. Both B and C are typically transmitted through blood and bodily fluids. And the guidelines really focus our attention on specific risk groups, primarily first-generation migrants from countries where these viruses are more commonplaces, like China, Turkey, Morocco. Also, people who use intravenous drugs and men who have sex with men, MSM.
One thing that surprised me in the sources was the mention of acute hepatitis C incidence actually rising. Specifically, it highlighted HIV-positive MSM, linking it to sexual practices that might cause mucosal damage or bleeding. That's, well, not the first transmission route you might think of for Hep C.
No, it isn't traditionally, but the data shows that trend, and it's concerning because acute Hep C has such a high chance of becoming chronic. And that leads us right into the chronicity issue. That's the fundamental difference between Hep B and C versus A and E.
So let's try to nail down that risk. Because for Hep B, it's incredibly dependent on when you get infected, right?
Dramatically so. The numbers are quite stark, actually. If a baby gets infected with Hep B within the first year of life, there's a massive 90% chance it will become a chronic infection. Compare that to an adult infection, where the risk of it becoming chronic drops way down to less than 5%. It really underscores why infant vaccination is so vital. We think currently around 40,000 people in the Netherlands have chronic Hep B.
And hepatitis C is even more likely to stick around, isn't it?
Yes, much more efficient in that sense. Up to 85% of people who get an acute Hep C infection will develop chronic Hep C. That works out to about 28,100 patients estimated to have chronic Hep C.
So what's the long-term damage we're trying to head off with treatment and management?
Primarily severe liver scarring, which is called cirrhosis. For both chronic B and C, there's roughly a 20% risk of developing cirrhosis over a period of, say, 5 to 25 years. And really importantly, these viruses can also lead directly to liver cancer, hepatocellular carcinoma, or HCC. And that can happen even before someone develops full-blown cirrhosis.
Okay, this sounds like it requires really specialized ongoing care. The guidelines are clear that treating HBV and HCV is now centralized. Patients have to go to specific hepatitis treatment centers. Why that shift? Was there a big change in treatment that made it so complex?
Precisely. Around 2012, the treatment options, particularly for Hep C, but also evolving for Hep B, became much more effective, but also much more nuanced. Monitoring, choosing the right drugs, managing side effects. It just got beyond the scope of most general practices. So the rule now is clear. Anyone diagnosed with chronic Hep B or C must be referred to one of these specialized centers. It's critical for getting the best outcome.
Could you clarify what a functional cure for hepatitis B means? It sounds a bit conditional, like cured with an asterisk.
That's a very good way to put it, yes. A functional cure means the virus is effectively suppressed to undetectable levels in the blood. The key marker, hepatitis B surface antigen, or HBsAg, becomes negative. So the active viral production has stopped. However, and this is the asterisk, another marker, the anti-HB core antibody, stays positive. This shows the body still remembers the infection.
And that memory poses a risk.
A significant one. The critical point here is that this sleeping virus, even in a functionally cured state, can be reactivated. This can happen if the person later receives strong immunosuppressive therapy, like certain chemotherapies or biologic drugs used for autoimmune diseases.
The suppression lifts, and the virus can roar back. That's why these patients need preventative antiviral medication before starting such treatments. It's a crucial safety step.
And for Hep C, the newer drugs seem almost like miracle cures sometimes, with really high success rates.
They are incredibly effective, yes. We see viral clearance rates well over 90%, often approaching 100% with the latest regimens. But another important caveat, successfully clearing the virus doesn't mean you're immune. The antibodies you develop aren't protective. You can, unfortunately, get reinfected with hepatitis C.
Okay, let's pivot now. We've covered the main viruses, but there's this huge non-viral elephant in the room, isn't there? Something linked much more to lifestyle.
Absolutely. We really need to talk about non-alcoholic fatty liver disease, or NAFL. Honestly, this is probably the single most common reason someone might have slightly elevated liver enzymes found incidentally on a blood test, often with no symptoms at all. The estimated prevalence is, well, it's huge, somewhere between 15% and maybe even 30% of the general population.
15 to 30%, that's staggering. And it's not just about the liver itself, is it? The guidelines emphasize wider health risks.
That's right. NAFLD is very closely tied to metabolic syndrome. Think type 2 diabetes, obesity, high cholesterol, or triglycerides, which is dyslipidemia. But the most critical takeaway, I think, for listeners is the cardiovascular risk. Having AFLD roughly doubles your risk of having a heart attack or stroke, and it increases your overall risk of dying from any cause by about 1.5 times. So it's a major driver of heart disease and mortality, perhaps even more so than its risk of progressing to liver cirrhosis for many people.
So the focus for management isn't just liver protection, it's addressing that whole metabolic picture.
Exactly. For patients with MLD who are overweight or obese, the cornerstone of management, the primary non-drug treatment, is lifestyle modification, specifically aiming for a 5 to 10% loss of body weight. Achieving that level of weight loss has been shown to reduce liver fat and, very importantly, lower that cardiovascular risk.
And just briefly, before diagnostics, we should mention the chemical culprits too, alcohol and medications.
Yes. Alcohol misuse, of course, can cause fatty liver. That part is often reversible if the person stops drinking. But continued heavy use risks progressing to permanent scarring, cirrhosis. And then there's drug-induced liver injury. Many common medications can be toxic to the liver in susceptible individuals. Things like certain antibiotics, amoxicillin with clavulanic acid is a classic example. Some anti-epilepsy drugs, statins, even overdoing it with paracetamol. Usually if it's caught and the drug is stopped, the liver recovers well.
Okay, so when doctors are checking for liver issues, the first go-to test is usually an enzyme called alanine aminotransferase, ALA. It's considered the most specific initial indicator of liver cell damage. When liver cells are injured, they release ALA into the bloodstream.
Right. And what levels should people be aware of? When does a high ALA become concerning? Well, a very slight elevation, maybe up to 1.5 times the upper limit of normal, might not be significant, especially if it's just a one-off. But if the ALA is persistently higher than that, say 1.5 to 10 times the normal limit, that definitely warrants further investigation to figure out why. And if you ever see an ALA level that's drastically high, like more than 10 times the normal value, that indicates significant widespread liver cell injury, and it requires immediate referral to a specialist.
Given that chronic Hep B and C can be silent for so long, screening seems absolutely essential, doesn't it, rather than waiting for symptoms?
Absolutely critical. The guidelines heavily emphasize proactive screening, especially in those high-risk groups we mentioned earlier. So testing asymptomatic people who've come from countries where Hep B and C are endemic is really important. If we wait for symptoms like jaundice or fatigue, significant damage may have already occurred.
For listeners who want to understand the tests a bit better, could we clarify the blood tests, the serology, especially for Hep C? How do you know if it's an active infection or one someone cleared?
Sure. For hepatitis C, the first test usually looks for anti-HCV antibodies. A positive result means that person has been exposed to the virus at some point in their life. It's like a footprint. But it doesn't tell you if the virus is still there. To know if the infection is currently active, you need a different test that looks for the virus's genetic material, called HCV RNA. If the HCV RNA test is positive, the infection is active. If it's negative, but the antibody is positive, it means the person had Hep C in the past but successfully cleared it. It's a resolved or Dorjamecte infection.
Okay, that makes sense. And for Hep B, the markers are maybe even a little more complex?
They can seem that way. The key one for active infection is the hepatitis B surface antigen, HBsA. If HBsAg is positive, the person has hepatitis B. Now, if they clear the infection, either spontaneously or with treatment, the HBsAg will usually disappear, become negative, but the anti-HB core antibody, remember that one from the functional cure discussion, that antibody typically stays positive for life. It's the long-term marker of past infection or exposure. Its presence tells you the person encountered the virus, even if the HBsAg is now gone, and that's the marker that flags the potential, albeit small, risk of reactivation later on.
Right. Okay, so bringing all these threads together, we've got the acute viruses, the serious long-term risks from chronic B and C needing that specialized care, and then this incredibly common issue of NAFLD with its own major health implications.
I think the key synthesis is this. Firstly, know your personal risk factors, travel history, country of origin, lifestyle choices, any existing medical conditions. That helps guide testing. Secondly, understand that if you do have chronic hepatitis B or C, management is now a specialized field. It requires referral to those dedicated centers for complex long-term care to prevent cirrhosis and cancer.
And it's worth highlighting, the sources remind us that acute Hep A, B, and C, as well as chronic B and C, are actually legally notifiable diseases. This means doctors have to report cases to public health authorities, the GGD, to help with tracing contacts and preventing further spread. It underlines their public health significance.
Yes, that public health coordination is a vital part of controlling these infections.
So here's a final thought to leave you with, building on everything we've discussed. We've established that the healthcare system mandates this highly specialized, centralized approach for chronic viral hepatitis B and C, affecting maybe 70,000 people combined. Meanwhile, non-alcoholic fatty liver disease, NAFLD, affects potentially up to 30% of the entire population and is a far stronger predictor of death from cardiovascular disease for many. Given the sheer scale of NAFLD and its associated mortality risk, perhaps the question we should be asking is, should early detection and comprehensive lifestyle interventions for NAFLD receive a similar level of centralized public health focus and resources as we now dedicate to viral hepatitis? Something to think about.